Hello, everyone, and thank you for joining May's Clinical Education Series presentation. Today's presentation addresses treatment-resistant depression. I am pleased to introduce today's speakers, Sue Anderson and Laura Longmock. Sue is a clinical pharmacy manager with Genoa Clinical Services. She leads a team of dedicated professionals and support staff as they help Genoa consumers navigate the first several months of taking certain newly prescribed specialty medications. Sue is also one of Genoa Healthcare's original certified instructors for mental health first aid. Since 2020, she has been helping Genoa team members at all levels hone their observation skills so that they can recognize and respond to mental health crises. Laura Longmock is the Clinical Quality Manager with Genoa Clinical Services. She manages the GCS quality program, helping to ensure that the clinical services delivered are of high quality, safe, and compliant. She works closely with the team to strengthen clinical practices, meet regulatory requirements, and drive continuous improvement in clinical outcomes for the consumer served. And without further ado, I will hand it over to Laura to begin today's presentation.
Thank you, Shannon. We'll start here with treatment-resistant depression, also referred to as TRD. This term generally refers to patients with major depressive episodes who have not adequately responded to at least 2 trials of antidepressant monotherapy. It's important to call out that these trials should be of adequate dose and duration and with appropriate adherence. Treatment-resistant depression represents a significant clinical challenge for healthcare professionals across disciplines. It's not a niche diagnosis, but rather a common trajectory for patients with chronic, recurrent, or complex depression. Many patients receiving care in outpatient clinics, community mental health centers, and integrated care settings cycle through multiple medication trials before achieving meaningful symptom relief from a regimen. It's estimated that about 20 to 30% of people with major depressive disorder experience treatment-resistant depression in their lifetime. In 2021, this was about 2.8 million people. This equates to treatment-resistant depression affecting about 2% of the general U.S. population, so quite a significant number of people. It is associated with an increased risk for hospitalization too. Patients with TRD are roughly twice as likely to be hospitalized for a depressive episode, and there is also increased risk for mortality and suicide. It is common for patients starting medications for depression to have to try more than one medication before their symptoms are resolved. Here we have a visual that may look familiar to many of you. It is from the STAR-D study, which is essentially the landmark antidepressant therapy study aimed to look at real-world treatment of major depressive disorder. The study took a step-by-step approach. If the first treatment didn't work, patients moved on to the next step. It was published in 2006, so a little bit ago, but it's still quite relevant. Patients in the study received 1 to 4 steps of antidepressant treatments of 12 to 14 weeks of duration. Patients who did not remit were not removed from the study. They instead moved to the next level of treatment. All patients initially received citalopram, and if they didn't achieve an acceptable response in the first step, they then had another treatment added to the citalopram, such as bupropion or buspirone or cognitive therapy. Or the citalopram was changed to another agent, whether that was another SSRI, bupropion, venlafaxine, or just cognitive therapy. And then again, they had the treatment for 12 to 14 weeks, and depending on this response, they moved on to the next step. So as you can see here in step 1, less than half of the patients actually experience an acceptable response to treatment. And so after that first step, they moved over to the next step. And still, only a small amount of patients actually achieved an acceptable response to treatment. As those steps proceeded, there's a significantly reduced response to treatment. And that's why it's really necessary for there to be alternative options available and other mechanisms of action with these medications. This study was done with treatments that were available at the time. So SSRIs, SNRIs, things like citalopram, sertraline, venlafaxine, and bupropion. It's been about 20 years since the study took place, and a lot of new agents have come out and more being investigated. Despite this study occurring a little while back, it still helps highlight that multiple trials of medications may be needed and often are, and it highlights the importance of coordinated longitudinal care and a reminder that treatment-resistant depression is a process, not a point of failure. And it's exciting that we have more options, and also now we have some time in treatment where we have patients who are experiencing these new options. In addition to the intangible burden of not achieving adequate response or full remission with each treatment step and residual symptoms, there's also a significant economic burden. This chart shows the proportion of total burden attributable to major cost categories among patients with major depressive disorder based on data analyzed in 2021. On the chart, the orange line in the middle represents the expected share of economic burden attributable to treatment-resistant depression. So this is the baseline comparator if the per person costs of TRD and non-TRD depressive disorder had been equal. To break this down, the information is showing how much treatment-resistant depression contributes to the extra economic burden among patients with major depressive disorder. It is really illustrating that treatment-resistant depression drives a disproportionately large share of costs, especially medical and societal costs, far above its likely share of patients. For example, though TRD affects about 30% of patients with major depressive disorder, it accounts for about 50 to 60% of healthcare costs. Taken together, this data shows that treatment-resistant depression is not just a clinical challenge, there are significant economic burdens too. And the next question becomes, what can we do to help improve outcomes in these patients? When we think about optimizing treatment in major depressive disorder, it really starts with getting the fundamentals right. First, regardless of which antidepressant class we're using, whether that's an SSRI, SNRI, TCA, or MAOI, we want to make sure that the patient receives an adequate trial. That means both adequate dose and adequate duration. These are critical to giving the medication a fair chance to work. In general, an adequate trial is about 6 to 8 weeks at a therapeutic dose, although many patients may require longer. And it's equally important in making sure that we're actually optimizing that dose over time. Alongside that, we also have to think about adherence. If a patient isn't taking the medication consistently or is missing doses, that's going to significantly impact their outcomes. So making sure dose, duration, and adherence are all addressed early can really improve the likelihood of a durable response. Another consideration if the treatment response isn't as expected is looking at comorbid conditions. We want to consider physical comorbidities such as hypothyroidism, Cushing's syndrome, Parkinsonism, malignancy, anemia, and nutritional deficiencies, as well as considering psychiatric comorbidities like substance misuse or dependency, anxiety disorders, eating disorders, personality disorders, and post-traumatic disorders. Addressing these factors can sometimes uncover other contributors to poor treatment response. If the patient still isn't responding adequately, we start thinking about adjusting treatment. This may involve switching antidepressants or augmenting the current regimen. Switching may be preferred for patients with minimal response or tolerability issues, and augmentation may be preferred in patients who had a partial response from the initial antidepressant. Common augmentation strategies include lithium or second-generation antipsychotics like aripiprazole, Rexulti, Vraylar, or Caplyta. Anytime we're layering on treatments, though, we want to continue thinking about practical considerations like adherence and cost, and the impact that can come along with adding additional medications. Another adjunct we sometimes see used is L-methylfolate. It's the active form of folate and plays a role in regulating serotonin and dopamine naturally. In patients who are deficient or who have impaired folate metabolism, supplementation with this product may help enhance antidepressant response, particularly since low folate levels can be associated with depression and a poor response to antidepressants. This leads into talking a little bit about pharmacogenomic or genetic testing. This is a tool that can be used to help guide treatment selection. While it doesn't tell us exactly which medication will work for a patient, it can help us understand how a patient may metabolize or respond to certain medications, allowing us to make more informed choices about medications and doses. For example, it may help us avoid medications with predicted drug-gene interactions or reduce side effect burden and therefore improving adherence, or inform when it might be appropriate to consider other treatment options beyond medications. Tying this back to L-methylfolate, genetic testing can sometimes identify variants affecting folate metabolism in a patient, which may support the use of supplementation in certain patients. And finally, we can't forget about psychotherapy. Psychotherapy or talk therapy is a core component of treatment and should be incorporated whenever possible, either alone or in combination with medications. Now, to bring this all together, there are some practical, high-impact ways we can improve the likelihood of treatment success, especially in patients at risk for treatment resistance. First, as I mentioned earlier, addressing adherence issues early and repeatedly. This is one of the most important and often overlooked drivers of outcomes. As clinicians, we want to proactively identify barriers to adherence and do that in a non-judgmental way. For example, phrasing conversations around this like, it can be hard to take medications consistently. How many doses have you missed in the past couple of weeks? Patients experiencing side effects are especially at risk, so anticipating and managing those early on can really be the difference between someone being a responder or a non-responder. Second, making one change at a time. As we adjust treatment, whether that's switching or augmenting, it's important to introduce changes in a stepwise way. That allows us to clearly understand what's working and, just as importantly, what isn't, without introducing too many variables at once. Third, administering adequate medication trials. I did mention this earlier, but before we decide a treatment has failed, we want to be confident it's truly had a fair trial. In most cases, that means 6 to 8 weeks, and sometimes up to 12 at a therapeutic dose. That said, if a patient shows minimal improvement, like less than 25 to 30% by that 4-week mark, it may be appropriate to consider next steps. And importantly, what can appear to be treatment failure is sometimes really inadequate dose duration or adherence, so we always want to reassess those first. And finally, encouraging patients to persist with treatment. This is where the therapeutic alliance really matters. Reassuring patients that we're partnering with them and that our goal is to help them feel better can go a long way in maintaining engagement, especially when progress might feel slow. So now that we've gone through those more foundational pieces, Sue is going to discuss some options on the market that can be used for treatment-resistant depression.
Thank you, Laura. The first current treatment we will review is esketamine, which is known by the trade name Spravato. The mechanism of action for Spravato differs from conventional antidepressant medications, and though it is not completely understood, it is thought to be through NMDA receptor antagonism, which affects glutamate. Esketamine is the isomer of ketamine, which is often used off-label for depression. Unlike more conventional antidepressants with a 12 to 14-week delay to efficacy, some Spravato patients experience a rapid onset of action with results within days or weeks. Commercially available as a nasal spray, esketamine is the first and only adults with treatment-resistant depression. It's also indicated for treatment of major depressive disorder with suicidality. Spravato has some advantages over daily oral therapies. For starters, initiation dosing is generally twice weekly for 4 weeks, then adjusted to once every 1 to 2 weeks, depending on patient response. You can find additional detailed information as well as some good visuals on how to determine the treatment frequency in the package insert and on the website. Another advantage is the favorable side effect profile. Esketamine does not carry the typical antidepressant side effects, such as weight gain or sexual dysfunction. Most of its side effects are transient and associated with the actual administration. These may include increased blood pressure, dissociation, and sedation. Due to these risks, Spravato can only be administered under the direct observation of a healthcare provider. While these advantages are helpful, cost is a potentially significant barrier. Many insurance plans will require a prior authorization. Generally, PAs require proof of 2 failed trials, which is common at this point in a treatment journey. Having the supporting documentation of those trials can be problematic for some patients. Another barrier is treatment time. Esketamine dosing requires a 2-hour monitoring period to watch for those administration side effects previously mentioned. That ends up being a lot of time at the clinic for the patient. Additionally, patients are not to drive themselves home after therapy is administered, so a driver is required. Despite the side effects and limitations, for most patients, the benefits of the treatment generally outweigh the risks. Our Genoa pharmacies see these barriers often, and the pharmacy teams have become good at managing and overcoming them. Genoa pharmacies work very closely with their partner facilities. They communicate daily and are able to jump in and help with insurance and patient support as necessary. Some Genoa sites also have a consumer medication coordinator who can help coordinate care, such as deliveries to the clinic or help with the paperwork needed for PAs. Some Genoa sites have access to a centralized team of prior authorization resolution specialists to help with PAs, or a team that can help overcome high copay barriers through Genoa Savings Connect. Fortunately, there are a lot of programs available to assist with cost. Genoa pharmacies are well positioned to help. Spravato is only available through a restricted program called Spravato REMS. The FDA requires a Risk Evaluation and Mitigation Strategy Program, or REMS, for medications that carry serious safety concerns. A REMS program is intended to ensure safe use of a medication and that the benefits do indeed outweigh the risks. While esketamine is a Schedule III controlled substance, the risk of abuse or diversion is considered low because it is only administered in clinic under the direct supervision of a healthcare provider, and patients are monitored for stable blood pressure and for symptoms of sedation and dissociation for at least 2 hours. Pharmacies must be certified to dispense Spravato, and most Genoa pharmacies are certified. If anyone is interested, you can reach out to your Genoa partner or the manufacturer to get connected to a Genoa near you. Next up is Symbyax. It is a combination of olanzapine and fluoxetine, trade names Zyprexa and Prozac. It is indicated for TRD as well as acute bipolar major depression. It is a once daily, fixed dose oral combination medication and is indicated in patients that are 10 years of age and older. An advantage of this medication is the 2 medication in 1 capsule formulation, which can lessen pill burden and improve adherence. However, once again, we see cost and a need for prior authorization as significant barriers. Even when it is approved by insurance, it is often high cost. One workaround to this high cost would be to prescribe the 2 components separately. While reduced pill burden is a noble goal and effective for compliance, if the patient cannot afford to bring it home, how effective was it? Additionally, since the trade product is a fixed dose combination, separation of the component parts can give additional flexibility to dosing. Third up is Caplyta. Caplyta spans psychotic, bipolar, and unipolar depression indications with a single fixed dose. While it is not indicated specifically for TRD, it can be an option for patients who have already optimized and augmented traditional antidepressant regimens. With its low dopamine receptor occupancy, it has antidepressant and antipsychotic effects with fewer dopamine-related adverse events such as EPS and tardive dyskinesia or emotional blunting, as well as minimal to no prolactin elevation. It also has low risk of weight gain and metabolic side effects as compared to older atypical antipsychotics. Barriers to therapy again include the ubiquitous cost and need for prior authorization. Once again, providers can turn to their Genoa partner pharmacies to help resolve these and improve patient access. Caplyta comes as a once daily formulation available in 10.5, 21, or 42 milligram capsules. Most patients will be prescribed the 42 milligram dose. The 21 milligram capsules are intended for those with moderate to severe hepatic impairment or when used with moderate CYP3A4 inhibitors. Patients concurrently taking strong CYP3A4 inhibitors are indicated for the 10.5 milligram dose. Next, fourth, we have Auvelity. This product is FDA approved for major depressive disorder in adults. Though it is not approved for TRD specifically, it can be an option to consider after inadequate response to first-line antidepressants. This one is perhaps a surprising combination. The active ingredient is dextromethorphan with a pharmacokinetic boost from bupropion. We are used to seeing bupropion as an antidepressant, but here it plays a supporting role rather than a starring one. In addition to its familiar action as a weak inhibitor of norepinephrine and dopamine reuptake, bupropion boosts the concentration of dextromethorphan by inhibiting the CYP2D6 process. Dextromethorphan enhances glutamate signaling by antagonizing NMDA receptors. So, as with esketamine, we have another mechanism of action that goes beyond the familiar serotonin pathways and into some exciting new territory. Auvelity has a brief titration period. It's dosed once daily for 3 days, then increased to twice daily dosing. Symptom improvement can begin within 1 week, significantly faster than traditional antidepressants. Similar to Symbyax, the component medications of Auvelity are available independently. Dextromethorphan is commonly available over the counter as a cough syrup, while bupropion is a prescription with favorable pricing. Unfortunately, you really can't quite recreate Auvelity. This is due to the time-release formulation and the dosing. The side effects are what you would expect to see from dextromethorphan and bupropion. It might be a good option for patients seeking a faster onset, non-SSRI option, and there are some copay assistance programs available. The fifth and final drug in our list is oral gepirone, trade name Exua. Gepirone is the first new mechanism serotonergic antidepressant approved in decades. It is a novel, selective 5-HT1A receptor agonist approved in 2023 and available since 2024. It works preferentially at postsynaptic 5-HT1A receptors. It stimulates serotonin without increasing overall serotonin levels. There is less data for Exua in TRD populations, but it is potentially an option. Exua is notable for minimal sexual side effects and minimal weight gain. It shares similar side effects to many medicines, such as nausea, dizziness, insomnia, indigestion, and headache. These are generally mild and typically minimized with time on the medication. Taking with food or in the evening can help lessen the GI upset. Interestingly, unlike SSRIs and SNRIs, gepirone does not block serotonin reuptake. It has minimal activity at other serotonin receptor subtypes. This alternative serotonergic modulation likely explains its distinct tolerability profile, particularly regarding sexual function and weight. Gepirone is not a first-line replacement for SSRIs, but it fills an important niche for adults with MDD who have partial response or poor tolerability to SSRIs or SNRIs, experiencing bothersome side effects like sexual dysfunction or weight-related concerns. It may be considered in patients with TRD before augmenting with an antipsychotic or as a mechanistically distinct switch option. Our final currently available FDA-approved treatment for TRD is electroconvulsive therapy, or ECT. It is a non-invasive procedure done under general anesthesia in which small electric currents are passed through the brain, intentionally triggering a brief seizure. ECT seems to cause changes in brain chemistry that can quickly reverse symptoms of certain mental health conditions. There are many misconceptions with ECT, but it is really quite effective. A treatment course is typically 2 to 3 treatments per week for 6 to 12 treatments. Generally speaking, patients undergo ECT along with taking an antidepressant or participating in psychotherapy. Patients may experience treatment side effects such as headaches, upset stomach, memory loss, and confusion. Side effects are generally short-lived and improve over time. In addition to misconceptions and the stigma that surrounds ECT, another common barrier is availability. Trained practitioners are needed, and since ECT is done under general anesthesia, an anesthetist team and all of their required supplies for administration and monitoring are required, as well as an appropriate physical space for the procedure. Beyond ECT, other non-pharmaceutical options include repetitive transcranial magnetic stimulation and deep brain stimulation. There is actually a new modified form of rTMS that was approved but has limited availability. So far, it is only at select treatment centers, but it compresses several weeks of conventional therapy into just 5 days. Now that we have reviewed several currently available treatments, let's switch gears a little bit, and Laura will walk us through some emerging treatment options for TRD. There are a number of interesting and exciting and maybe a little surprising things being investigated. We will discuss a few today. Laura.
First we'll talk about is NRX 101. And this is a fixed dose combination of D-cycloserine and lurasidone. Lorazepam may sound familiar since it's already available on the market as Latuda. NRX 101 is being studied specifically for bipolar depression with suicidality, which is an important distinction. In terms of mechanism, the thought is that D-cycloserine, which modulates the NMDA receptor, may work synergistically with 5-HT2A antagonists like lorazepam. The goal is to potentially enhance antidepressant effects while also improving tolerability. Looking at the clinical data, phase 2b/3 studies showed similar efficacy to lorazepam alone in terms of depressive symptoms. However, the study did not meet statistical significance on depression severity endpoints. That said, there were signals of benefit in suicidality and tolerability, which is really where this treatment may differentiate itself. So clinically, how do we think about this? Rather than a broad antidepressant, NRX 101 appears to be more of a targeted, suicide-focused intervention designed to maintain stability after an acute intervention. In terms of status, phase 2b/3 trials have been completed and regulatory discussions are ongoing, but it is not currently FDA approved. Earlier, we mentioned Spravato or esketamine. This is the isomer of ketamine. IV ketamine is not currently FDA approved for depression, but it has been used off-label for many years, and its use in treatment-resistant depression has increased over time. While some patients do experience benefit, data around long-term safety and efficacy are still limited. Similar in mechanism to Spravato, ketamine is thought to work through NMDA receptor antagonism, impacting glutamate pathways, although the exact mechanism isn't fully understood. Generally, between the two, Spravato tends to be preferred. This is largely because Spravato comes with standardized dosing and administration, required monitoring through the REMS program, and potential insurance coverage. That said, though, for patients who still want to pursue IV ketamine, it's important to guide them toward reputable treatment centers, such as those staffed by licensed board-certified providers with appropriate safety and emergency protocols in place. Another key consideration is durability. The effects of IV ketamine are often shorter-lived, typically days to weeks rather than months. So without a clear continuation or maintenance plan in place, this can be a limitation in sustaining benefit over time. Lastly, we'll look at psilocybin, which is currently being studied for major depressive disorder, including treatment-resistant depression. In terms of mechanism of action, like many of the agents we've discussed, it's not fully understood. However, it's thought to work through modulation of the serotonergic system, particularly via 5-HT2A receptor agonism. From a research standpoint, this has been somewhat challenging to study, largely because psilocybin is classified as a Schedule I controlled substance, which creates barriers to access and trial design. That said, early findings have been promising, even in relatively small studies. One of the notable aspects is the speed of response. In some studies, patients have shown meaningful symptom reduction within 1 to 2 treatments or within the first couple of weeks, which is quite different from traditional antidepressants. Many of the protocols involve limited dosing sessions like once weekly treatment, often with structured psychology support alongside treatment. More recently, there's been progress with synthetic formulations, particularly COMP360. Earlier this year, phase 3 data were released for COMP360 in adult patients with treatment-resistant depression, showing positive results in terms of symptom reduction. The study is still ongoing to better understand durability of response and long-term safety. Though it is still investigational and more data is needed, it represents a novel and potentially rapid-acting approach, especially when combined with psychological support, certainly an interesting option in the pipeline. So we've talked through the science, the treatment strategies, and some emerging therapies, but at the end of the day, all of this really comes back to the patients we're treating and what treatment-resistant depression actually looks like to them. Sue is going to share some of these stories.
Thanks, Laura. We have heard from a number of patients about the relief they have gotten from their treatment-resistant depression. One patient noticed his Spravato seemed a little slow to work in the first month, but now in his second month, he has noticed a difference. He describes now having an ability to sit with himself and reflect, to be in his body and check in with himself. He feels that he's a little more able to weather difficult moments and contextualize or reframe certain feelings he's experiencing. He's hopeful there's still more to come with his journey, but is happy with the definite shift he's noticed in how he's feeling. Another patient shared that they had been taking an SSRI along with an adjunctive second generation antipsychotic, aripiprazole, for over a year, but he continued feeling down with bouts of anger. He noted his mood was, in his words, just tanking, and he wasn't feeling like himself. His regimen was switched to taking the SSRI along with Caplyta, and he noted that within a week he started to feel 100 times better, had never felt better in my life. As he continues on this combination, he's been able to maintain his improved mood and feels hopeful that this will be the right regimen for him. Finally, as an example of the necessary trial and error, level of effort, and stacking of treatments often needed to achieve remission of treatment-resistant depression, we look at Jenny. Jenny is a 49-year-old female diagnosed with MDD at age 16. Her baseline symptoms were fatigue and anhedonia. She has comorbid lupus. Jenny has an extensive history of antidepressant treatment failures, including multiple SSRIs, SNRIs, and bupropion. She also has a history of psychiatric hospitalization and suicide attempt. Over the years, she's had a long-standing engagement in psychotherapy, and she has benefited from both partial hospitalization programs and intensive outpatient programs with dialectical behavior therapy skills. Those and ECT have reduced her suicidality, but were limited by cognitive side effects. Her current TRD management uses a multimodal combination approach with escitalopram, abilify Maintena, lamotrigine, and IM ketamine. Jenny continues with ongoing psychotherapy and is also planning to incorporate trauma-focused work into her treatment. She has described this regimen as her sweet spot and reports that her baseline fatigue is improved and her baseline anhedonia is largely resolved. Jenny's experience is a reminder to us that patients with TRD can achieve remission. It takes patience and some experimenting with options to find the unique combination for an individual patient, but relief can be found. In closing, the treatment-resistant depression journey can be complex, and it looks very different for each patient. For some, remission can be achieved with the addition of a single adjunct. For others, TRD can be a decades-long path. This journey is a partnership between the patient, the practitioner, and the pharmacy. We must collaborate to ensure the patient understands the importance of adherence and the timelines involved. The practitioner must understand the barriers the patient is facing and assure each medication is trialed for an appropriate duration. And the pharmacy must have the information needed to support appropriate dosing and ensure interactions with other medications are avoided. Given all the different medications and treatments currently available and on the market today, as well as all of the new ones under investigation, we are gaining more and more different options and types of treatments for patients, which is exciting. Each of our patient stories circle around to the point that these patients have found a treatment that is right for them, a resource to help push themselves forward. It wasn't magic. It was the right tool at the right time that gave them relief, along with the ability to work on themselves. Being trusted with these personal stories is an honor and deeply rewarding. When patients have found meaningful improvement in their quality of life, it affects not just themselves, but it also impacts everyone around them, their loved ones, their friends and families, and even their coworkers. Thank you for your time and attention today and for joining us. If you have any questions, please reach out to your Genoa Partner Pharmacy. They are a great resource, and if they don't have the answer, they have the ability to contact us for support. I hope everyone has a great day. Thank you.
Wonderful. Thank you so much, Sue and Laura. This concludes today's Clinical Education Series presentation. Thank you so much for joining. Next month's presentation will dive into a new drug that has recently hit the market called IGALMI, which is used to treat acute agitation in patients with schizophrenia or bipolar disorder. Please stay tuned around mid-June for this content. It will be available on our YouTube channel along with all of our other presentations at www.genoahealthcare.com/center-partner-resources. Thanks again and have a great rest of your day.